obsessive compulsive disorder. I think you would have studied a little bit about that. First, we'll have a look at the epidemiology. And it has been found from few studies done in the past, the prevalence of this disorder is between 1 to 3%. At the beginning, it was thought it is rarer than schizophrenia because in the early days they didn't know that, but there were some descriptions about this disorder as far back as 1600s, but later they found the prevalence is actually more than schizophrenia. So it somewhere ranges between 1 to 3 and usually around 2%. And the male to female ratio is 1 to 1 in adults. Do you have any idea what's the ratio among children? Or who has it most? Is the male or female population in children, boys or girls? Girls, boys? No, there's a male preponderance among children and adolescents, but then it changes to 1 to 1 when they become adults. And the OCD in children and adolescents, it is slightly different in terms of presentation compared to adults. Okay, so first let's go into the criteria. So I would be happy if you tell me what do you know about the ICD-10 criteria. We better stick to ICD-10 because back there we use more DSM-4 and currently 5, but in terms of OCD, there isn't much of a difference between ICD-10 and DSM-5. So what is the criterion for, or the major criteria for OCD? The first one is the patient should have either obsessional thoughts or compulsions or both. So they don't need to have both all the time, okay? And the ICD-10 criteria say that patient should have at least 2 weeks duration of these symptoms of significant distress, whereas the DSM-5 doesn't specify a time duration for the presentation. And what's the difference between a trait and a disorder? I'll be discussing that later, that it is usually, many people have obsessional traits, as you would know, and it's more among professionals, people like you, the medical students, because it helps you to organize your life and to be highly successful and to achieve. But when it goes beyond a certain level, it causes distress to yourself as to people around you. And that's the time we call it a disorder. So there should be a significant distress to the patient, or there should be some disruption of your personal and social duties, okay? Then, so these are the characteristics of obsessions, that they are first recognized as own thoughts. So that is a significant differentiation from what you experience in schizophrenia, where sometimes patient may say that I get these thoughts, but these thoughts are inserted by someone else. So here, the patients retain fully inside, so they know the thoughts are theirs. And then there would be resistance, as you could see. It is one of the major criterion of OCD. There should be subjective resistance, because patients understand this is nonsensical and this is purposeless thoughts, and they want to resist that. And there should be, the criteria say that there should be resistance to at least one thought among, if they have many. So that is one of the marked features of OCD. And thoughts are repetitive and they are intrusive also, giving significant distress. And the last criteria in ICD-10 is that it should not be pleasurable. Say, we will discuss about that cycle of OCD later, but as you know, when the obsessions arise, these repetitive, intrusive thoughts arise in patients' mind, it causes significant distress. And then to relieve that anxiety and distress, they perform the compulsions. And then the distress goes away and they become relaxed and relieved. But that is not pleasure. So it actually, what it tries to differentiate from is from any sexual deviance, or where the thoughts and the acts can be deemed pleasurable, but at the same time intrusive and a little bit distressing. So it is different, okay? And here I put the asterisk here as ego-dystonic. It's not one of the criteria, but as suggested by the first criterion, even though it's their own thought, it's coming from their mind, it is not something they are happy with. And so when the thoughts are pleasurable, or thoughts are in accordance to what they want or something, it is called ego-syntonic. Whereas, and some delusions are ego-syntonic, and patients believe, yeah, someone is persecuting me, and they completely believe in that, and they go along with that. Whereas ego-dystonic is, the thoughts are theirs, but they want to avoid that, and it causes distress. So that is called, it is ego-dystonic. And the one difference from the DSM-5 criteria is that it says thoughts are not just worries about real life problems. And what does it try to differentiate? What's the meaning of that? Why? So where would you get thoughts, repetitive intrusive thoughts, which are real life problems? In which condition? Yeah, PTSD and depression. When in severe depression, even the trivial life issues, they would sort of magnify, and they would ruminate on them again and again, like their future and those things. And even some anxiety disorders like GAD, generalized anxiety disorder, but the difference is those are day-to-day mundane issues, but they will ruminate a lot. But you can't say that those problems don't exist, whereas here it's not just them. There are specific themes in OCD which comes repeatedly, so it is not simply real life, what am I going to do tomorrow, what is my future, or not thoughts like that, okay? Okay, so these are the forms in which obsessions can present. Are you aware of what are the forms mentioned in ICD-10? Because not all of these are mentioned in ICD-10. Do you know among all these? ICD-10 talks about only 3, the thoughts, then the impulses, and the images. And the DSM-5, instead of impulses, it uses the term urges, okay? But I put the other 3 because it can present in that way as well, but it's mostly covered by the thoughts section, okay? So thoughts, in the sense here, what we talk about is people get just a simple phrase like, things are dirty, this is contaminated, if I touch this, the germs will come into my hand, or this is blasphemic, or something, that sort of thoughts. So it's just a phrase or sentence which would come into their mind again and again. Whereas impulses, what do you think about impulses? How do they present? And what's the difference between a thought and the impulse? Yeah, the impulse is and something dangerous or very unpleasant, like when they are by the traffic, suddenly they might get an impulse to jump across the traffic or jump from a height. It is not going to happen, and they never will do that, but still they get these impulses, and they fear whether they would eventually do that. So that is the major worry that would come repeatedly, and in response to certain circumstances that may lead to some kind of an avoidance as well sometimes, right? Images, it's very explanatory, so they get a number of images. Images can be part of obsessions, and images can be part of compulsions as well, and those compulsions are called covert compulsions. We can talk about that later. So there are a number of different types of images. One is, first, the obsession can come as an image. Say, for example, someone touches the table and they get a feel that whether some germ has entered their body or some dirt. And they can even visualize that. touching that and some sort of infection in their fingertip or something. So it is the obsessional image, it is called. Then there's this compulsive image, say someone touches contamination and their compulsion is washing hands. And they might get this image in their mind as washing hands again and again. And some images could be destructive images, like because in contrast to depression, in obsession, their major worry for the patient is not about harm to themselves, but it's more about harm to others. So if you probe their thought deep inside, you will find that, say for, again, taking the example of contamination, say, they say, I get a germ, I get an infection, but if you say, what will happen? And that's what when we assess the patient, we ask them, what will happen next? So the question will be then, whether it will spread to my family or my parents, and whether they will die or my spouse will die. So ultimately, it will go into some destruction of some harm to other person. That's what they fear. It's not about whether I am going to die. It's more about whether my action is going to do any harm to someone close to me, someone known to me. So in that case, some of the images may be destructive, like seeing that person they are concerned about dying, something like that. So there are different types of images which you can categorize in obsessions as well as compulsions as well. What is a rumination? Have you seen OCD patients in your clinical appointment? You have, yeah? So any ruminations you have come across? Compulsion. Yeah, it's primarily, especially when it is rumination, you hardly see any accompanying compulsion. You can define it that way, but just to define that, what it is, what do you mean by rumination? What's the difference, say, from a thought of, if I touch this, I'm going to get contaminated? It is not a rumination, it's just a thought. So in what form the rumination will occur? What do you think? So the rumination is something, it's just like a spiral of thoughts. So it may be, patients may be debating in their minds about different, say, the purpose of life. Say, what will happen, and I live, and I get old, and I will die, and what will after that? So that kind of a rumination. Or it could be about, in their own mind, there are two opposing sides debating with each other, like, say, taking a circumstance, what is the good about that, and what is the disadvantage, whether to do that or not to do that, some sort of a back and forth arguments, and it will go on like that. So it is not just a simple thought, so it is a repeated spiral of thoughts happening again and again and again. And ruminations are, in terms of therapy, are a bit difficult to control. So, so simple obsessive thoughts are much easier in terms of treatment, whereas ruminations are a bit difficult. Phobias. Fear, any example you can think of? And phobias are usually characterized by avoidance. So avoidance is a major criterion of phobia, defining phobia. So there should be avoidance. So what you said about checking is the doubt. Whether I closed it properly, whether I turned off the gas properly, so those are the things, or otherwise something will happen, some security or some safety breach will happen. So that is the last part, the doubts. Phobias is, again, as I said, that people become concerned whether they would harm other people. Say someone gets this obsessive sort of impulse, like when I see the knife or something, when I see a baton or something, to hit somebody or harm somebody. That's the obsessive impulse they get. And secondarily, they try to avoid that area, or seeing that weapon, or even going into the kitchen in the fear that they might grab a knife and hurt somebody. And and it will lead to avoidance. So in that context, we call that a phobia. Okay? So these are the many different forms of obsession. So these are the common themes. So I guess you would have come across contamination, as I explained to you before, is a common theme, and symmetry is even in people with traits, you can observe things should be neat and clean. The table should be all in order. Things should be arranged properly, and they don't want that to be dearranged by anybody, and they get annoyed because of that. And some people like to keep things symmetrical, like the shoes should be in order when it is placed. So these are common themes in symmetry. And obscene blasphemy, you would have heard these examples. I guess some people get these in the books. It's commonly cited that people get these impulses to utter blasphemic, some sort of condemning the religion or the deities or something like that when they are in religious places, or some sort of obscene sexual related images coming into their mind sometimes. So these are common themes. And when it comes to some sort of a sexual related themes, sometimes they find it pleasurable, and at the same time they develop guilt about that. So there are some sort of differences from the common the criteria, and guilt and harm to other people. So these are common themes. Any other themes you heard of in your clinical, any patients you come across? So one of you said you saw a patient. Which theme the patient had? Contamination. Anything else? Okay, so it's more of an image that is okay. Good. All right. So this is compulsion. So ICD-10 defines that as repetitive behaviors, right? So the mental acts actually is not mentioned in the ICD-10, but it has been found compulsions can. So compulsion, ICD-10 takes it as it's only behavior where you can see the person performing that, whereas mental act is not mentioned there. But lately it has been realized compulsions can occur covertly inside in your mind, in patient's mind, rather than anyone observing outside. So and they are performed in response to obsessions. And as I said before, that when patients perform compulsions, it actually decreases the anxiety, the distress, and they feel relieved after that. So it is done to avoid that, and they themselves realize those are excessive. So it should be beyond the level. If you wash hands 2 times, we are not going to call that as compulsion, whereas if it is multitude of times, then it is definitely distressing to the patient. So these are the criteria from ICD-10, whereas DSM-5 mentions this obsessional slowness. So any compulsion can be associated with some sort of a slowness. Say if you wash your hands 10 times, definitely you are going to get late getting ready. So something like that. But there are people who become extremely slow, and they take hours and hours to finish tasks, and they could be categorized as obsessional slowness. And it doesn't happen in all the patients with obsession. So that is very different from the usual slowness observed in OCD patients. And the DSM-5 also says it takes up more than an hour per day. So the compulsions, if you put it together, they have to perform at least 1 hour per day in compulsions. Okay. Okay. So these are the common compulsions: washing, checking, counting, it could be mental, so it may not be observable to other people. And some people in pray, especially people who get these deviant thoughts and sort of guilt thoughts, they tend to pray as compulsion. And some people just arrange things again and again to make things in order. So these are called overt compulsions, which you can observe from outside. Whereas covert compulsions, as I mentioned before, it wasn't recognized in the past, but lately it has been found with these covert compulsions, we call them as neutralizing thoughts. So what happens is patients get a distressing thought, and to reduce the distress, they do something covertly. They may pray inside their mind to the God, or they may utter something inside, they may think some peaceful, everything is going to be all right, or something like that, to reduce their distress. And overt compulsions, of course, you can address easily in therapy, because you know what it is happening, and you can ask the patient not to do that, and you can control the patient. Whereas covert compulsion, it's very difficult to treat, because you just can't tell the patient don't do that, because at the same time they might be doing that repeatedly in their mind. So they are a bit difficult to treat in the therapy. So as I mentioned before, the trait versus disorder. So many people have obsessional features. We don't need to call them even traits then, and it is part of our life to bring some order and to perform well, and then it becomes trait. And lately I will talk in the personality disorder about obsessional compulsive personality disorder trait, and then it becomes OCD. The trait will help people to some extent, but when it crosses the boundary of causing distress to patients or social disruption, then we call it as disorder. So not everyone with some sort of OCD is not disorder, but at the same time, if you have a trait, you could be more predisposed to develop a disorder. So that is one of the risk factors for OCD. So there are multiple theories about the etiology of OCD, and you would have heard about them. Serotonin dysregulation, how did it come about? Why people thought OCD could be something serotonin related? You have heard about that, I believe. You would have read. So how this theory came about, you think? What made people to think that it could be serotonin? It's almost like it's sort of a retrospective sort of speculation, because they used the anxiolytic agents. Most of them are serotonin, SSRIs and TCAs, and they found these patients get better, especially clomipramine, which is a predominantly serotonin related antidepressant, and they found it's quite useful in these patients. So they thought it could be serotonin related, but it was initially thought, since in depression there was a low serotonin and they get better with SSRIs and TCAs, it was thought that this could also be related to a low serotonin. But what they found was, it's actually whether the serotonin is low or high. It's more about there's a dysregulation in the circuits, serotonin circuits in the brain, involving various brain regions, and the brain regions usually involve the orbitofrontal. So OCD could be part of the frontal lobe syndrome, and then it involves the caudate nucleus in the basal ganglia. So you could say that OCD could be part of Huntington's chorea, and sometimes the post-streptococcal manifestations like Sydenham's chorea, and after rheumatic fever you may see especially children with OCD, and then it involves the thalamic circuit. So it's frontal, basal ganglial and thalamic circuits are involved. So there's a dysregulation. It doesn't mean it is increased or decreased. So there is some problem in the connection. And what do you know about the genetics? Is there a high heritability of OCD? Have you seen? Yes, so usually parents with that is part of the family history we ask, and we found that it is more in the children when the parents have OCD traits. But what is not known is whether it's more genes or it's more learning, because these children would have grown up watching their parents doing these compulsive rituals, or sort of expressing obsessive thoughts or reassurance seeking. So perhaps it could be a learned behavior as well. But even in twins reared apart, they found that there's a certain degree of concordance between them. So it can't be learning then. So there's definitely a genetic part in the transmission of this disorder. Then the psychoanalytic and cognitive theories. What does psychoanalytic, the Freudian theory, says? It's just for more academic. What do you? Yeah, it's sort of a regression into anal stage. So, you know, the oral, anal, genital stages of the Freudian theory. So, in the anal stage where the child strives to achieve some control over their bodily functions, their excretion and those things. So, obsessive people are more rigid, controlling, they need everything in order and they don't tolerate disorganization or disarray. So, that sort of a controlling, they regress, they are arrested in the development. So, they become more OCD like develop traits later in the life. So, that is just for your knowledge. And the cognitive theory is interesting. As I said before, the OCD people, they are more worried about harm to others, not to them. So, they think if you think something, that will happen. So, if I think my friend is going to get into an accident, then it will happen. It doesn't stop with that thought. So, they think it will happen, and if that happens, then I am going to be responsible. So, feeling responsible for the harmful acts happening to others is part of their cognition. So, it's all about their compulsions, is all about avoiding that sort of harmful thing happening, even though they realize it is nonsensical and it doesn't have a meaning. So, this is we can call it cycle of reinforcement. So, for some patients, OCD can have a precipitant. There could be a precipitating event like an exam stress. So, a person with already some OCD traits can develop some disorder like features near stress, and usually it resolves when the stress is past. And or some people, when they have the traits and they develop other comorbidities like depression or other anxiety disorder, the OCD traits can sort of manifest into a disorder like presentation. So there could be a precipitant, or there need not to be a precipitant all the time. And what happens is then they develop the obsessions, and then when you develop the obsessions, you think, so it is going to cause harm to someone, and then this anxiety comes up, what am I going to do, and those things. Then they perform these compulsions, and once the compulsion is performed, the relief comes, then it becomes a positive reinforcement. So, the next time, so what they don't do is they don't stay with that anxiety. So, they never know what will happen if they stay on with the anxiety and with the thought, okay, let it happen. But what they do, they run and do these compulsions, which brings the relief, which is a positive reinforcement in some sense. And the next time the obsessive thought comes, then they will rush to do the compulsion. So, then it becomes a cycle, repeated cycle, and it becomes more and more frequent. So, they think once they perform the compulsion, it stops. It doesn't. It will come on repeatedly. So, this is called the cycle of reinforcement. So, if we look into the differential diagnosis and comorbidities, first is depression. So, we discussed a little bit about how we can differentiate. As I said, the depressive thoughts are more about their future, what will happen to them and harm to them, whereas OCD is more about harm to other people. And of course, in depression, the rituals won't be there, even though there would be, sometimes it would be very difficult because you get these ruminations again and again, and the patients, sometimes depressive patients may come and say, how to get rid of these thoughts coming into my mind, and it's a very difficult DD, I would say, differential diagnosis. But they won't have these compulsive rituals, and from the quality, if you take a proper history and assessment, you can easily differentiate the depressive cognitions from OCD thoughts. Have you seen OCD with schizophrenia, any patients? You have? Anybody? You have. So, what's the difference between just simple OCD and OCD comorbid with schizophrenia? Yeah, they would have other schizophrenic symptoms, definitely, or more like some delusions on top of the OCD thought, but anything else differentiating? So, one patient comes with repeated thoughts. Because OCD can be a differential diagnosis, and OCD can be a comorbidity as well in schizophrenia. So, if it's a differential diagnosis, the patient reports some sort of repetitive thoughts. How would you know this is part of schizophrenia, or it's simple OCD, or is it something mingled with schizophrenia? How can you, what's the difference between OCD occurring in an otherwise normal person and OCD occurring in a schizophrenia patient? No idea. Okay. It's very interesting. We have seen patients like that. So, if you take first the differential diagnosis, sometimes patients' delusions may appear as intrusive obsessive thoughts, and some delusions patient may retain some insight. So, in that case, it may be a little bit difficult to differentiate, especially if the patient had some OCD traits in their past as a part of their personality. But in schizophrenia, usually the delusions are very bizarre, the way they expressed are bizarre, whereas OCD is more neurotic spectrum, so it is more understandable. The contamination, the illness phobias, those are more understandable in comparison to all the paranoid or persecutory grandiose stuff the schizophrenia patients expresses as OCD. But as comorbidity, the ICD rules out schizophrenia as a comorbidity, because it says if the patient has schizophrenia, then you can't diagnose OCD, which was proven wrong later. Now there is wide acknowledgement that schizophrenia patients can develop OCD, and you can diagnose them separately as OCD and schizophrenia. We have seen some, but the difference is when OCD occurs in a patient already suffering from schizophrenia, the obsessive thoughts can be a little bit bizarre. So, it is not the usual themes like contamination or blasphemy or illness phobia or anything like that. They can take some bizarre turns, like I have seen patients burning books and those things. So, there won't be much resistance to the compulsion and to the obsessions as well, and they may lack insight, but that does not mean they can't have it. And there is a new concept called schizo-obsessive syndrome, schizo-obsessive disorder. It does not come into any of the, there isn't much of a acknowledgement about that people recognize. As I said, some schizophrenia patients coming with OCD on top of their psychotic symptoms, they are coming with some OCD like symptoms, repetitive thoughts, which anyway has some sort of a bizarre turn, there some sort of a bizarre content, and it's a bit difficult to differentiate whether this is OCD because it doesn't look OCD because it is bizarre, but at the same time it doesn't look purely schizophrenia as well, because patient himself complains that it is repetitive, he wants to get rid of that and he tries to resist. Okay, so we don't see many patients like that, but there can be patients like that. So when OCD occurs in the context of schizophrenia, there could be a sort of a symptom overlay, and you could see some bizarre features there, right? Not abnormal features. Tourette syndrome, you heard about that in child psychiatry? Have you? Tourette syndrome, you haven't? So, yeah, the vocal tics and the motor tics combination, when the vocal tics can be sort of distressing and sort of obscenic repetition. So, Tourette syndrome could be, so it is basically a tic syndrome, and OCD is commonly associated with tics. And if you have seen children who had the post-streptococcal manifestation, they usually develop tics along with some of them with OCD symptoms. So, it goes hand in hand, and I think ICD-10 also excluded this as if OCD happens in the background of Tourette syndrome, you can't diagnose that separately, which has been proven wrong now. So, you can actually diagnose them both simultaneously. Other anxiety disorders like phobias, say when a patient comes with phobia, sometimes it may be difficult to differentiate between whether it's phobia of that nature or is it an obsessional phobia. But in case of true phobias, there would be significant avoidance and the related cognitions, and they won't report that as repetitive and intrusive, because phobia is more situational. say if you have a phobia, arachnophobia, it will develop only when you see a spider and not all the time, whereas obsessional phobias can be, it could be more repetitive and it can stay, it may be more sustaining. And organic mental disorders, I talked a little bit about them. Any disorders in specific you are aware of? Have you seen? So, as we discussed, the frontal, basal ganglia and thalamic regions are involved. So, any damage there or any infections or anything you can get. So, post-encephalitic OCDs can happen, and then OCD can be a part of the frontal lobe syndrome and all these basal ganglia, these Huntington's chorea and stuff. Okay. All right. Any questions? Anything you want to ask about at this point before going into treatment? So, the basic tenets are CBT and medication. So, we will talk a little bit about CBT, because we can first, in terms of CBT, it is done a little differently for the different kinds of presentation. As we said, that the patient can present with purely obsessions or predominantly compulsions, or both, a combination. Because some obsessions, like ruminations, and they may not proceed to have accompanying compulsions. It may be just the rumination, and they may have some covered neutralizing thoughts. Whereas some people present with predominantly compulsion, and if you try to extract the accompanying or preceding obsessive thought from them, because obsessions usually precede the compulsions, you won't be able to get that. They say, I get this urge to perform this function again and again, I don't know why. So, they are treated a little differently, whereas some patients would have both predominantly existing in their presentation. So, they are treated a little differently in terms of CBT. Before going into that, or to a certain degree, so it is, and to engage them in CBT may be a little bit difficult, because to understand the cognitive principles and to use them in the therapy would be a bit difficult for the children. And some of the organs differently, like if you, I don't know whether you have seen any of the post-streptococcal OCD manifestation. They develop, those, especially those children, their rituals are a bit different, and they may not be able to give you the exact obsession preceding that, and their rituals may be about, say, touching the doorstep, more like a magical thinking. When they pass through the door, they have to touch the doorstep, or they have to touch the table for some good luck to come, or they may sort of, when they walk in the paving stones, they may jump from one to another. They have to walk in a certain way. That sort of some sort of a magical thinking more would be present more in their case, and it may not be preceded by any clear-cut obsession. So, they present a little bit differently. So, what are the CBT techniques you are aware of? You have done? No. You have seen anybody doing CBT? Have you heard about, say predominantly compulsion. So, patient says, I get this contamination obsession and I keep this compulsion to go and wash my hands repeatedly. How would you address, proceed with this patient in terms of therapy? Okay, what would you do for the core belief? So, the core belief is, if I touch the germ, then you probe, so what will happen? And he might say, someone is going to be harmed by infection and they are going to die because I passed the infection to them. So, how are you going to do that? Exposure. So, as many of the compulsions are preceded by obsession, but for patients like these, where the compulsion is very obvious, very visible and easily treatable, we first address the compulsions. So, as you said, it's exposure and response prevention. What does that mean? Yeah. So you expose them to the trigger. So the trigger is seeing something dirt or touching something. And surprisingly, I forgot to tell you that some patients say they may get this feeling like I have to keep everything in order, or this is dirty, in response in only in particular situations. Say for example, they may feel the dirt when they touch the table, but at the same time they may not have the same feeling when they touch a door or something. And some people would be their rooms would be immaculate, very neatly arranged, symmetrical. But if you go to the office, or if you have a look at their car, it would be in total disarray, and it doesn't cause any distress to them. So it could be very situational. So so you have to address the problem in that particular situation only. So that should be part of your history taking. Where does it actually occur? Whether it is sort of pervasive, affects all aspects of the patient's life, or it is just one sort of an area there. And so in simple obsessions and compulsions like this contamination, first because addressing compulsions are easy because it's obvious, it manifests in a particular way, and you can stop them doing that. So what you do, you expose them, and then you ask them not to perform the compulsion, and the patient would say, I'm going to get distressed by that. And usually what we do, we draw a graph to them. Unfortunately, I didn't put it here. So what we do, we say, when you are getting exposed, of course your anxiety is going to go up and up. And what you do, usually you run and you do your compulsion, and the anxiety falls sharply to the baseline. And you think if you don't do that, the anxiety is going to climb, and it is going to become so unbearable, or you are going to die, or something like that. So you never know what would happen if you don't perform the compulsions. So what we say, we draw a graph like a sort of a mountain-like graph. So your anxiety is definitely going to go up if you don't perform the compulsion, but then it would anyway come down, because anxiety is more noradrenergic response. Once your transmitters get depleted, and then everything would come back to normal, and you will feel. But what happens normally in your disorder is you never allowed that to happen. You think that's how you stop it, and you don't know the natural cause of your anxiety. So that's what we are going to show you. So you have to explain these things before start of the therapy, and you expose them, and you prevent them from doing rate the anxiety between 0 to 10 sometimes, how it is going up and when it is coming down. And also usually the anxiety would go higher and would last longer in the first time, and then subsequent exposures it will come down. So you can show that in the graph, and they will also, with the progress of the therapy, they will also identify that, right? So that's how it is done. So that is for predominantly patients presenting with predominantly compulsions. And you have to give homework to the patient to go and do that, because in the therapy in an hour, there's a limit to what you can do. So it's always good to engage the family members as co-therapists, and some patients' obsessions could be also associated with reassurance seeking. So everything is all right, what do you think? Sort of they will go back to their family members and ask those questions, to ask the is it going to happen, and they say no, and they feel happy and it's sort of relieved, then they go back and ask reassurances. So it's always good to engage the family members as part of the therapy, first to prevent the compulsions like that, and for people asking for reassurance, they could say, of course you know the answer, I'm not going to say anything to you. The anxiety would definitely go up, but then they will learn how to deal with that as part of the therapy, right? And so this is part of that. So cognitive therapy, so this is more behavior therapy, even though the CBT is, you have a cognitive element and you have a behavioral element. So people with predominantly compulsions, you do the behavioral element. Then you do the cognitive therapy for predominantly patients with obsessions, and you can't see any overt compulsions like ruminations. How do you think you can do that? What's the part of the compulsive cognitive therapy? Any thought on what can you do? A person coming with repeated ruminations and no compulsions outside, so you can't ask them to stop it. How would you ask a person to stop the thought or to stay with anxiety? So for ruminations, as I said before, staying with anxiety is the major tenet of the therapy, because patients do the compulsions to get rid of the anxiety very quickly. So in terms of compulsions, of course, we prevent them from doing the compulsion, and they stay with the anxiety, and then it comes down. They learn it. Whereas in terms of predominantly obsessions, you can't ask them to do that, because they may say, of course, I am staying with the anxiety, I'm thinking about it. So in terms of obsession, staying with the anxiety means thinking that rumination again and again without trying to get rid of that, because trying to get rid of that is the sort of a compulsion to decrease the anxiety. So they may try to get rid of that by having some covert neutralizations, like some other comforting ritual-like thoughts, which you may not observe outside. So what you can do is how to make someone stay with the rumination, stay with this distressing thought. So there were some techniques before which is completely opposite to that. They do the thought stopping, like a rubber band technique. You flick the rubber band, it causes pain, then you get distracted, so the anxiety goes away. But the current sort of principle is patients have to stay with anxiety to deal with this problem, and they know by thinking of this thought repeatedly, nothing is going to happen, no harm will happen, and that will reduce the anxiety. So in that sense, what one of the techniques we studied were to ask a patient to write the rumination again and again. So when you write it, you have to think and write, so you can't get rid of the thought, you have to be with the thought. So the anxiety will go up when you write it, and then it will come down, and they can grade it and rate it as well as a graph. The other technique of staying with the thought, I hope you understand that treatment here is staying with the anxiety, not getting rid of the anxiety. That is the basic principle of OCD, right? Not getting, not like treatment of other sort of depression or other conditions. So here in obsessions, the other technique we use is a loop type. I'm not very sure how often it is used, because patients with purely cognitions, they are very difficult to treat, and they may not come for treatment early on. So, this therapy is what you do. You ask the patient to record their thoughts, like to express it outside and record it, and the loop tape will repeatedly play it. Like once the cassette is over, it will play it again and again and again. So when you hear it, you have to stay with the thought. You can't hear something and think about something else, so they can't get rid of the thought. So then the anxiety will go up when they hear it again and again and again, and it will come down, and they will understand that it will sort of, this is how will happen if I let my anxiety to run its natural course. So that is a learning they do during the session, right? So usually with patients with predominantly compulsions like the contamination, when you address the compulsion, the obsessional preceding obsessions will automatically come down, and you don't need to do a specific cognitive therapy for them, because cognitive therapy is for obsessions, behavior therapy is for compulsions. So you just with behavioral therapy you can sort of resolve the patient's problem. But in terms of patient predominantly cognitions, then you have to do only the cognitive therapy. There is no behavior to address there. And there is a group of patients where first you have to address the behavioral problem, and then once the cognitions have improved a little bit, then if they are still remaining, the obsessions, then you can do the cognitive therapy. So you have to choose which therapy to use first, depending on the patient's presentation, but the behavior therapy is relatively easier to use
because you can engage the patient can understand what is happening, and even the family members can understand and you can engage them. As cognitive therapy, patients struggle a little bit to understand actually what is there, what they have to do, why they have to stay with the anxiety sort of thing, right? Images are very difficult to address. One technique is to think about the focus on the image, make it sort of shrink into their visual field, a sort of mind visual field if you could call it, and to make it a pinpoint and disappear. But they are really difficult to, because in a loop tape you can record the thought and play it. How can you record an image and ask the patient to stay with it? So it is somewhat a difficult thing to address. And patients with phobias, with avoidance, of course you can actually make them exposed to the situation if they are avoiding going to the kitchen, or where the trigger is, that you expose them, stay with the anxiety and engage the family members as well. What are the benefits of cognitive therapy, or CBT? In comparison to medication? No side effects, yes? Yeah, patients will be involved, and patients with insight, definitely they will willingly, and many patients are averse to medication, so they would happily engage with that. Anything else? Complaints? Yeah, compliance, that depends, because CBT means you have to come in person to see the therapist at least once a week, and logistical difficulties, whether they will have a time in overseas, they will have to pay for the psychologist, there's financial issues, so there would be, and how much the patient is willing to engage may also be a problem, because sometimes it's the family members who bring the patient, not the patient themselves, because they are such a disruption at home. So in that case, how much the patient would be happy to engage in the therapy would be doubtful. But one of the major advantages is it is longer lasting than the medication. So the medication usually, once the medication is stopped, we see a significant percentage of relapse, whereas in CBT the benefits are sustained for a period. But they can still get a relapse when they are exposed to stressful situations, but they can use the same principles, and partially, at least partially, they can treat themselves if they learn it properly, the behavior therapy. So there is the disadvantages, as I said, it's time consuming, and patients have to make the traveling and the financial, those things. And CBT is more for people who are educated, so, and who can understand these sort of cognitive principles about anxiety, who retain insight. So if it is children with very poor insight, we still do successfully in children, for many children, but sometimes it is not as easy as in adults. So if it is a patient not happy to engage in therapy, or doesn't have much of an insight with some other comorbidities, it may be a bit difficult. So especially when patients significant distress, the distress itself may distract them, and they may not be able to engage in behavior therapy, CBT. So in those patients, first we use the medication to sort of reduce the anxiety around this disorder, and then we use the CBT. CBT we start with once a week, and it can go up to 12 weeks or 15, and once the patient gets better and start to have some control over their disorder, it can be tapered down to about say once in 2 weeks, once a fortnight, or once a month, and then, and if they relapse, you can give a booster session after that. So if we go to medication, so these are the medications, predominantly serotonergic acting. So we prefer SSRIs, even though they are a little less effective than the clomipramine, which is a TCA, because SSRIs have less side effects, whereas the clomipramine has more significant side effects, and the tolerance would be less. And for resistant patients, some patients, the antipsychotics we can add in a little dose, and sometimes there are some glutamatergic agents and there's Riluzole, so there are some newer medications, but mostly it is more antipsychotics. And if the conditions OCD occurs in the context of a depression, depressive episode, when you treat the depressive episode, usually the OCD also comes down. But when an OCD patient develops depression, secondarily, usually both the OCD features and the depressive features usually go up. So, but when you treat them together, they usually come down. The major disadvantage of medication is, of course, the side effect. Then also the patients have a lot of stigma about medication. They may not be willing to take it, but finally, the relapse rate would be higher once it is stopped. Okay. But the current guideline is to give both together for better effect. So the medication they suggest, it could be given to at least 2 years, at least 1 year for patients, otherwise the relapse rates would be higher. And patients, so it runs a fluctuating course. They may wax and wane, and you hardly see any patient who just had one episode and remain completely well for the rest of their life. So it usually recurs. These are the better prognostic factors if you catch it early and treat them, say within weeks to months. And when there's a precipitating event present, like near the exams or some serious life events, and they continually function well despite the OCD, and the symptoms come episodically, and unfavorable are the childhood onset, and say comorbidities like other anxiety disorders, substance abuse, because some patients with distress can go on to abuse substances, and then severe depression or anxiety along with OCD.